Hi, Chapter 45, Alterations in Musculoskeletal Function in Children. First couple of slides just go over normal growth formation, which was covered in earlier chapters. Just kind of look over it if you're not aware. This one just talks about the growth of the bone, and the big takeaway here is the epiphyseal closures. So until the epiphyseals close on the top of the bones, and there's a picture later on of this, this is where the bones grow. Any kind of infection or fracture or something like that that affects this area of the bone can cause permanent length discrepancy in people. So if you've got a fracture and it says through an epiphyseal plate, make sure that you pay attention to that. That's important. Talking about the different factors that affect bone growth, which of course we know is growth hormone, nutrition, general health. That's why it's important for children to have a good diet. We get our most bone mass up into the 20s. That's why it's important for teenagers, especially teenage girls, to make sure they're taking in their calcium. Skeletal development. Babies are kyphotic at birth. They had little rounded backs, and then their neck starts becoming lordotic when they start kind of holding it up. You can kind of read this. Total growth of the spine, or 50% of the growth of the spine at 1 year of age, with about 70% at age 8. Age 8 is kind of a big deal with a lot of growth things. You're getting to your maximum lung capacity about that time as well, so that's an important time in development. Genus Vargum. Bow legs, normal in babies. Usually you'll have this says peaks at 2.5 years, but you can really see it once they start walking, year and a half. But it's usually gone by about 2.5, 3 years, and then they go from that to genus Valgum, which is the knock knees, and so you go from bow-legged to knock knees, and that's normal development. So if you don't do that, or if either one of these persists past these kind of like 6 years, 3-year periods, then you think about some pathological causes. These are some pictures of these different processes. So Blount's disease would be getting into some of the pathology. With Blount's disease, and you think about people that have been extremely overweight. Pedis plantis, this is where babies have flat feet, really normal. Your arches usually are developed by age 6. About 10 to 20% of the population continues to have flat feet, not really a problem unless it's causing them a problem, say. Toe walking, real common in kids up to about age 3. If it's consistent, if they're always toe walking, or they are toe walking beyond the age of 3, then you have to start thinking about CP, muscular dystrophy, that sort of thing. Pigeon-toed, real common in children between 8 and 15 months of age. If it goes beyond that, you can actually have femoral anteversion, which is like twisting of the femur. Muscle development, here you can read about that. It's pretty self-explanatory. So this talks about some congenital defects, and they talk about syndactyly, and then they have this vestibular tabs, vestibular tabs. Syndactyly is just where the digits are fused. You can have this on the fingers or the toes. They can be just partial fusion, like up, or like total fusion, like this. There's partial and total here. They can be bilateral or unilateral. They can be linked with other congenital abnormalities, so be aware of that. Polydactyly is where you actually have extra digits, and they can be just little nubbits of a digit like this to really fully formed digits. The most I've ever seen is 10 fingers on a baby. I don't think that baby survived, though. I can't remember. Mostly what you see is just little nubby things. Like this is pretty formed, and this would have probably should have been surgically removed when she was young, but usually it's just a little piece of skin there, and it kind of flops around, and we can just tie it off, or actually what they use a lot like now is just staple it off close to the skin, and then it'll just kind of like fall off like their umbilical cords. Congenital defects, they're going to go into this a little bit now, and this goes into hip dysplasia. You do not want to miss hip dysplasia. So when you're checking children, and I check them up until the age of 2, I've got a YouTube video, and I was going to link it here, and I thought you can't really see this from the video, so I have a link in your resources pages on how to do these tests. Real important, I do them every time with every well visit up till about age 2. Also remember here, if you got someone that's really low tone, for whatever reason, they have CP or they have some kind of brain injury, continue to check those hips because they can kind of like fall out of place. So I'll see that a lot. The kid didn't have congenital hip dysplasia, but they've got acquired hip dysplasia just from probably being so low tone. So just kind of be aware of that. This can cause all kinds of problems if you miss it, though, and it really shouldn't miss it. These tests are very simple. This is just some pictures here of developmental dysplasias, what's going on. And some of the clinical manifestations. So you'll see these asymmetric gluteal folds. So if you look at the back of the baby's thigh, you'll see like the lines on their thighs are different from one side to the other. But basically you're going to see a positive Bartlett or Ortolani test. If you are seeing a problem waddling, we've got it way too late. And then that just talks about treatment. This is basically what they use, is this Pavlik harness, and kind of holds holds the hips in an abducted posture to allow the seating of the femoral head. Now we just go into a little bit more foot deformities, which I added those slides up there about some of that stuff, so some of this may be a repeat. So basically when you are looking and you want to know if it is clubbed foot, or if it's just positional, interning of the foot, which can happen a lot just from interuterine position. If you can pull the foot out into a normal position, don't really get too worried about it. May need a little bit of splinting, but not usually going to be a big deal at all. Usually just sort itself out. But if you cannot manually pull the foot out into a normal position, then you need to be concerned about that, and that needs a referral to an orthopedic doctor. So here is some casting that they would do. Of course, this is down the ways a bit. They're not going to start off there. Osteogenesis imperfecta, there's many different types of this. This is actually a really interesting disease. And these kids their bones just break for nothing, for no good reason. And like I said, there's types. They've got 1 through 4 here. Some of them are lethal. They're not going to do well at all. Some of them are going to do, outgrow it. I have one little boy in my practice like that. He's had, I couldn't even tell you how many fractures this poor little kid's had. But he has tended to outgrow them as he's gotten older, and the bones have gotten more ossified. So he's real lucky with that one. But there are definitely, the mom is definitely, or parents are, abuse is always concerned, and it should be. But once they do have the diagnosis, I mean, they can break their leg just changing their diaper. It's kind of a terrible disease. Rickets, unfortunately, we're seeing a lot more rickets than we used to, just because we're giving our kids Coke instead of milk when they're little. Okay. Some of the symptoms of this. Fractures, kind of one of the big things that we see with this as well, especially in our premature babies or something that just haven't had enough time to get the nutrients that they needed in utero, and if they've been if they were difficult to feed and if they've been on like a Hyper-L type of diet, they are definitely at more risk for rickets. Okay, so this is kind of some of the things that affects scoliosis. We will go over scoliosis more. This is something you definitely need to check. Scoliosis affects boys and girls. Basically, once the child has stopped growing, we don't have to get too concerned. The spine has to have like a greater than 50-degree curvature before they really get too upset about it. So that's pretty big curvature. But if you're seeing scoliosis, you know, my thing is I let, especially here, since we got Shriners down the street, I let the folks over there take a look to make sure they wouldn't do anything about it. Usually I refer them over and they say, ah, it's fine. But we've got them there. It's a great resource. So if you're out in the community, you could just continue to watch it. You can get spines and they can spine x-rays and they can tell you the degree of curvature in those, and you can just keep watching it until it gets to the point where you need to do something about it. This is just some of the differences. I believe that you have already covered this. If you have not covered this, you will definitely cover this with screening test for your F&Ps next semester on how to check for this, but you've probably covered this in your physical assessment class. Bracing and then surgery, and that surgery just sounds amazingly terrible. Osteomyelitis is more common in children before the epiphyseal plates have sealed. Anytime you get a red swollen joint, that's a concern. Osteomyelitis is not much fun. Remember, if you have somebody that's complaining because their knee hurt, it could be referred pain. So if someone's knee hurts, you always check their hips. Okay? And if their hip hurts, you check their knees. You kind of go, the rule of thumb is up or down one joint and kind of check that one out at 2. Just don't forget about that one. This is the I guess one of the indications they're saying that you could have more infection here. I think they have a slide a little further down. Alright, so I'm going to bump down to one of these later slides. I think it kind of explains this a little bit better. And, you know, osteomyelitis is super difficult to treat. So this is basically showing the epiphyseal plate, and I guess once you have this down here, then you have less chance of getting an infection. It is something we see in kids. Fortunately, not often. All right. So what they're talking about, just symptoms. You got fever, you got tenderness, you got a red on joint, you got a kid that's not bearing weight. These can be very difficult to treat. So, you know, you don't want to miss it, but you don't want to destroy the bone if we can help it. Juvenile arthritis. It's got here the basic pathologies like adults. This is it's a terrible disease. Juvenile arthritis. So some of the difference between juvenile idiopathic arthritis and rheumatoid arthritis is that JIA is a group of chronic arthritis disorders. And there are different types, where rheumatoid arthritis is a single disease. Many people with JIA find that their symptoms actually subside as they get older, where rheumatoid arthritis does not. About 50 to 70% of children with JIA can experience periods of remission and have no disabilities. However, it can cause malformation of the bone. People with rheumatoid arthritis are more likely to have rheumatoid factor, so it's more useful for a test for diagnosing rheumatoid arthritis than it is for juvenile.